Morning everybody and welcome to University Hospital Liverpool Group's Assurance and Risk Committee for the 7th of August 2025. Thank you for your attendance. Look forward to a good meeting. We have got a very big agenda and a big pack of papers, so I will push us along as we can. We know that our site updates take most time, so there's been an hour set aside for that. So we'll, again, watch the time and make sure that we do conclude by 11:30, because I know people will have got onward meetings. So, okay then, so can we start off with apologies, please? I've got David Florey, Jim Gardner, Sarah Walker and Chris Maudsley. Anybody else? Nope. Lovely, thank you very much.
Sorry, Jackie, sorry. The only other one I think is Matt Connor, and Matt, I think, is doing the board of directors at the Walton Centre this morning.
Right, okay, thank you. Matt Connor will capture that, thank you. Okay then, so our minutes of the meeting for the 3rd of July, is everybody happy with that they are a true record? Yep, thank you very much. And then on to our rolling action tracker. We've got two updates. The first one probably being the biggest one from Natalie, which is around the 2-week wait metrics. And then I'll bring Daniel in to talk about the second one. So over to you, Natalie.
Do you want me to update that now, Jackie, or when I go through the performance part of the Royal?
So I'm thinking there's a cancer issue across the whole of it, but I'm happy for you to do whichever you think is better.
Yeah, I can cover that now. So the question last time was on the deteriorating 2-week wait position and understanding it in more detail. So I suppose I'll just start with the context, Jackie. So nationally, the 2-week wait rule has been removed from the national standards because of the change in pathways, because previously patients would have had multiple appointments, they'd have come and been seen, and then they would have come back for their diagnostic. And nationally we've been encouraged to move, and the clinical pathways are moving to sort of one-stop shop clinics. Yeah. So the national standard is we must see and diagnose the patient, and they must know their diagnosis within 28 days of the date of referral. So that's the faster diagnosis standard in the IPR. You can see in May, sorry, I'm just going to mention the Royal because I know the Royal and Broad Green stats, we were at 75% for the Royal. Now, at June, we're at about 77%. That's still undergoing validation. And I've just run through July, and it's looking like we're closer to 80% for July. So we are seeing improvements. When you look at that at a tumour group level, you'll remember at the Royal we had significant issues with breast. Breast are achieving over 85% now on the faster diagnosis standard. The issue with the 2-week wait is most patients, for example, in breast are getting their appointment at about 22 days. So they're getting one appointment, it's outside of the 2-week wait, but when they come in, they are getting all their scans, their diagnosis, and then they're moving on to treatment plans. So within the tumour groups, the areas where we had pressure are upper GI. So that relates to gastroenterology and endoscopy. Now, back in April, May, when you can see that deterioration, we're about 55%, but in July, we're at over 80% achievement on upper GI, and that's related to the additional endoscopy capacity that we've invested in. The other one that is an issue is urology. So we're at about 60% for the urology faster diagnosis standard within that overarching. But again, we've approved the urology business case, and we are recruiting and expanding the urology capacity. So we are on an improving trajectory on the faster diagnosis standard, but there is some pressure within specialties, but we are tracking that at specialty level. But I suppose that's just explaining why the 2-week wait looks like it's coming down, but it's because most patients, this across most of the specialties, are getting one appointment on about day 21 or 22 at the minute, but they are getting the diagnosis at the same time, which is different to how we'd have previously done the cancer pathways.
Thank you. That's really clear. Thank you. Tom?
Thank you very much for that, Natalie. I wonder if you can comment on melanoma.
Okay. As in, sorry.
Time to diagnosis. I know we've got problems in dermatology.
In dermatology, yeah. So I've just reviewed their data, Tom. So dermatology, although we've got problems, it's generally in the elective side of things. We've been prioritising the skin cancer pathway. The latest data I've just seen on validated for July is an 89% faster diagnosis standard compliance for skin. So the main issue in skin is because we're prioritising the cancers, we've got pressure on the electives, which I'll update in my report, which is where we see some of the 52 and potential 65-week pressures that we're managing in dermatology. If you look as well, Tom, at the broad green IPR, the only cancer pathway they have is skin. So you'll see that that's basically the dermatology data in that IPR.
Thank you very much.
Thank you. Any more questions on this? So can I just ask Natalie,
Yeah.
will we see this 2-week wait coming off if we're moving to a different system? Because I think it does cause some confusion, doesn't it, if it's not there and that. So as we're showing it, and we don't need to. So is that going to change?
I've just had the discussion with James. We sign all the changes to the IPR off through execs, and I've suggested that I'm going to take a proposal to remove the 2-week wait standard from the IPR. And then what we need to be focused on is the improving trajectory that we need for the faster diagnosis standard. So I'll take that proposal to execs in the next couple of weeks, Jackie. Thank
you. That's really helpful. James?
Yeah, so I think that I would agree that that's probably the right thing for us to do. What's came in as late as Friday, which is really good actually, is Jim Mackey and Penny Dash wrote to all CEOs to effectively give us a new dashboard, which includes for both 18 weeks, the 52-week standard, the cancer diagnostic standard, the faster diagnostic standard, 62-day performance, 6-week wait, A&E 4-hour and A&E 12-hour. They've just created a dashboard of every provider with your individual ranking against the metrics to be updated every month. And we've never had quite that level of information before. So, and execs haven't even been through this yet, but just looking on that, for FDS, Luft ranks 97th out of 122. So you can see that we have got some work to do on FDS to get to where we need to be. Whereas on 62-day cancer, we're 57th out of 122. So what we'll be able to do now is in the dashboards that we put together in the IPR, I would suggest we include our relative ranking alongside those 6 key things as well, because it's always been a bit of a discussion, hasn't it, in our meetings, our board meetings in ARC, where we sort of say, well, we're here, it's better, but there's no relative information as to whether we're good in Cheshire Mersey, but Cheshire Mersey is not very good nationally, and therefore we're at the bottom of the pile or the top. So we've now got these national sort of rankings for the key standards. So I think we'll take it through execs, but I think dropping the 2-week number, concentrating on FDS and 62 days, but then putting our ranking for that month for each of the organisations alongside it would give NEDS greater assurance as to sort of whether we're improving compared to everybody else in the benchmarks as well.
Thank you. If there's no more questions, we will move on to the second item on the action tracker. So, Daniel, do you want to take us through this?
Yeah, certainly, Chair. Basically, at the private board of directors last month, the board members were considering the draft set of risks to go onto the new board assurance framework for the group. One of the queries that was raised was to ask the ARC to consider the addition, and it was asked to look at 2 particular areas. One was in relation to research and innovation, and the other one was in relation to quality. We've undertaken a further review of the BAF risks and the discussions that took place at the board workshop. We've also compared BAF risks through some guidance from Mersey Internal Audit Agency and looked at other organisations of a similar size and complexity. We're suggesting that there is a new 9th risk added to the BAF risks, which relate to quality, that would be led by David Mealy as Chief Nurse. This has been discussed with David in advance of today's committee, and we're proposing that there's a risk which states there is a risk that we are unable to maintain standards of safety and care, with patients suffering avoidable harm and poor outcomes. As a result, this will also affect the experience for patients, increase pressure on staff and services, and increase regulatory scrutiny. So we're proposing that that is added to the board assurance framework with the next update as part of the normal cycle to the public board meeting.
Thank you, Daniel. I can see no hands. So with those two items, are we happy to close them now as complete? Yeah, lovely. Thank you ever so much. So I've not been made aware of any urgent matters arising. Is there any from anybody? No. Okay, lovely. Okay, so we're now down to the reports from the sites. So we are starting off with you, Pete and Aintree.
Thank you, Jackie. So the paper is there. So just some highlights from it. So there's currently 14 risks of 12 and above at Aintree. There is one risk at 13, which is the discharge risk, which has been there for some time, 6425. I'll cover it when I talk about urgent care, but we are considering reducing that risk slightly now to 12 because of the no criteria to reside position bill. I'll come back to that. There's two new risks on the register this month, both related to elective standards, 9058, which is the RTT 65-week risk, which again I'll come back to when I'm talking about where we are from elective position. And then there's one new risk related to what we've just been discussing there around the cancer standards, 7026. So there's a typo in the report, 7026, which relates to the cancer standards. As you can see, we had a drop in performance at the turn of the year at Aintree. We put an action plan in, and that was recovering performance, as you can see on the IPR on both FDS and 62 weeks. There was a slight drop in month, which was related to a very specific pathway in ENT. As we reviewed that at HMB, that issue is now resolved. But nonetheless, I've just asked for a paper to come back through our finance and performance to ensure the action plan still is the right action plan, and I will get assurance on recovery of that. But I've kept that risk at 12 for the moment. And so then if I just go through the sort of three key areas, so of urgent care, we do have the three risks that remain, 6425, 8247, 6457. In terms of performance, the 4-hour performance remains in normal cause variation with 48% against 55% target. The key focus in that area to improve that position is continuing to stream patients through our same-day urgent care unit, but also some work we're doing around acute medicine and same-day urgent emergency care, rest deck area, to improve our particular non-admitted performance, which will drive that overall 4-hour performance up. In terms of the other key metrics within the urgent care, 12 hours in department. Currently, Aintree is performing about 15% of patients staying more than 12 hours in department against a target of 10. The focus there is continued on the continuous flow policy we've introduced within Aintree, and also driving down the no criteria to reside issues. Those two things are intrinsically linked. So that is our key target key focus to improve that area. In terms of ambulance handover, we have seen some improvement in month, with a reduction in the number of patients waiting for more than 45 minutes. However, performance still is not where I want it to be. And average performance is still 49 against a target of 45 minutes. As you know, Aintree has been part of the pilot for the ambulance handover 45, and we have learned some lessons from that, which we are currently implementing, and so hoping to see continued improvement. That is again an area of key focus around our urgent care strategy. Again, good performance remains, around 15 minutes to triage and 60 minutes to treatment, and you can see that there's now been a shift change in the SPC chart because of the 8 points above the mean, around 60 minutes. And then finally, in urgent care, the no criteria to reside position has improved. We're at the month of the IPR we're reporting, we're down to 157 patients deemed as no criteria to reside, which is the lowest it's been for some time. That has allowed us to get our temporary escalation spaces closed and some ward closures, which is improving the CIP position. And the final bit on that, we are seeing improvement in patients, the pathway 3 patients who are due to go to residential home. The time taken to get patients from discharge or from point of discharge to a nursing home now is reduced from previous average of 24 days to now 15 days at Aintree, so that's a good improvement. We're going to review all the risks, the three risks around urgent care, because I think they were at a time when really there was these sort of different CQC pressures around our urgent care. So I just really want to go through, make sure they're worded correctly and capturing our current action plans. So these all three may change next month. They'll remain, but they're just the wording and the controls. I just want to make sure we're actually reflecting the current position as opposed to where we've been, because there's been so much improvement in that area. Just moving through to elective care. The key risks really to discuss here are 9058, which is the new risk around RTT and the 65-week in particular. Aintree remains continue to be challenged around 65-week position. That challenge remains primarily in head and neck, mostly ENT. We had to revise our trajectories for recovery at the beginning of July, and those trajectories were essentially hit at the end of July. We're now looking at what the position is going to be, and in liaising with CMAS and the ICB on our position for the end of August. I have put in some enhanced strengthened governance for August, particularly around PTL monitoring and clinical validation, and Beth's team are also helping out in that area through the month of August to make sure we are getting that position recovered as quickly as possible, and I will continue to report on that, but that risk remains 12, and that's one of our key challenges at the moment in Aintree. In terms of other elective care risks, the 8645 risk around 6-week target to diagnostics, that remains 12. I previously reported there was an issue in sleep. That's now been recovered. The issue now is purely focused on our echocardiography position. We've now got capacity and demand in balance around increasing our capacity around physiology, capacity and demand control with referral validation. The problem is a backlog, and we're liaising with the ICB how we manage that backlog, but that risk will remain 12 until that's resolved. And then finally, I'm just going to come on to the financial position. Two key risks, 9050, 9051, that's our expenditure and CIP position. But in summary, year to date, Aintree is 2.3 million behind plan. In terms of the income and expenditure position, income is essentially ahead of position year to date at 1.25 million, 1.21 million a month. Non-pay is essentially in balance, although some pressure in month 3 and non-pay, particularly around consumables, which we are reviewing. That's theatre consumables, which we're reviewing. That brings us to the key issue in Aintree, which is the pay position that is driving our overall year-to-date plan position. 1.3 million behind plan in month for pay, and 3.1 million behind overall year to date for pay. So that's our key risk. That's been driven by non-achieved CIP, our sickness absence position, and also premium pay, and particularly the non-registered nurse fill position around special obs, which we got plans around. So a lot of focus in that area. In terms of CIP, we're 0.5 million ahead of position year to date at 8.6 million against the target of 8.1 million. We delivered 1.8 million in month. As you will see later on the PwC paper, that we were given some actions to achieve by the end of quarter one of which was to get all our CIP plans into, or 75% of our CIP plans into ready to go positions. So I can confirm that Aintree has 75% of the CIP plans in blue and green as we stand. And then finally, just on the IPR, there's nothing else to raise that I haven't covered, apart from, unfortunately, we've had another MRSA bacteremia, which is disappointing. We had a frank conversation about that at HMB. We've re-looked at our plan. It's again related to cannula care. It's on a different ward to the previous wards. We still think that plan is the right plan, so the focus now is on making sure that the plan is followed and implemented. So some key conversations going on with the clinical teams around cannula management to improve the MRSA position. So I'm going to pause there and take any questions.
Thanks, Pete. Jeff, Marie.
Thank you, Jackie. Thanks. Very good paper. My question on the money side. Obviously had an increase in income, and presume without that might have been even worse. What needs to happen to get the pay back to where it needs to be?
So the key focus, Jeffrey, as I was saying, is really trying to deliver the CIP position. So whilst we're ahead on CIP, if you look at the money side of it, that was there was some one-off adjustments, as you know, in month 1. So it's coming back to making sure we're delivering on our CIP as planned, particularly the whole time equivalent transaction. That should improve because of some of the UEC position, we are now able to get some further wards closed in July, so that should improve the pay position in July.
So we're now in August, so we'll say October, will we see a real improvement on that position?
That is so with the pay position the substantive pay position will improve because of the ward closures in July. Yeah.
And the second point is about the non-criteria reside, really good progress. What do we think would be an acceptable level that we would think is bearable? You know, I presume you can never get down to zero, but what would we think is the period we'd like to get to?
So we have got trajectories in that, Jeffrey. So we're trying to bring it down by 30 per month. That's really to deliver the ward closures. So we're pretty much on track for that in terms of this reporting position. As you say, I mean, it's a bit. You don't want any patients who remain in hospital unnecessarily, because that's a risk and decondition, etc. But obviously, the University Hospital Liverpool group position is above sort of where you would look at average nationally. So at least going back to average nationally would be a start. But the trajectories we have set ourselves are all around what we need to do in terms of delivery of the ward closures.
And the final question on the non-criteria is: how do we compare with the rest of Cheshire and Merseyside?
I think I need to get the figures out, Jeffrey. But I think we're up. We're certainly on a high. Nationally, we're certainly higher than average, and so that is we do stand out on that.
Good. Thanks very much. Thank you. Thanks, Jackie.
Thank you, James.
Yeah, I can just come back on the Cheshire Mersey position. We're the only area that's improving on NC2R to any sort of degree. So compared to others, we are improving, but others are not. But Cheshire and Mersey remains high against the rest of the country, as Pete said. My question was just on the MRSA, and Pete, you touched on there. We think the plan's the right plan. I'm paraphrasing, but we just need people to follow it. Why aren't they following it? So in terms of when you're going back to it and looking at it, if we've got the right plan, but it's not working, I just want to understand exactly what that, maybe flesh that out a bit more. Why is that?
Yeah, so that's essentially the conversation we had at HMB, right. James. It was a frank conversation, and essentially, I think the issue is that this MRSA is in the surgical division, whereas the previous were in medical division, and so a lot of our implementation of the plan effort went into medicine, and less so in surgery. So we're now flipping that and focusing the implementation of the plan really into the surgical division. We didn't do anything in surgery, but the key focus was medicine because that's where the previous ones were, and then this has now emerged in surgery, which is disappointing. So some key actions for our surgical leadership team to make sure that everyone is aware of this plan and is following it, because we do, as I say, we went back around the loop and we do think it is the right plan.
Okay, thank you.
David, did you want to come in on that point?
Yes, if I may. Thank you, Chair. So just to continue on with Pete's comments, there are two areas in IPC that we're going to focus on particularly. One of them is IV access and good and proper management of that, and the other is around catheter care, because we know that that's where the large number of the gram-negative infections are stemming from, and it isn't down to the fact that our policies are in place, our policies are appropriate and follow national guidance. It's around the human factors around people not adhering to what they should do. And it's how do we get that local ownership and leadership, both from a clinical and a ward management approach, that are monitoring their colleagues' behaviour and practice. So that's the focus now from IPC.
Thank you. Tom?
Thanks, Jackie. So two questions really for both sides. One is around the no criteria to reside patients. It's great we've seen such improvements. My question really is, given that so much of this is outside our control, are we confident that this is going to be sustainable? We're not just looking at a summer lull here. And my second comment really is around the antimicrobials within 1 or 3 hours of diagnosis in the A&E department. The figures between the two sites are still quite different, and I'm sure this is down to a reporting issue and not to any real difference in clinical practice. So I'm sorry Jim isn't here, because I know this has been a particular focus for him, but the difference is still stark and we need to find an explanation for it.
In terms of the no criteria to reside, I mean, absolutely, we can't have this as a sort of blip and then retract back to where we were, Tom. If I'm honest, there was a little bit of slip back the month after this beginning to happen, so we've again had redoubled our focus. I agree. Some of this is out with our control, but not all of it. So we do need to make sure that we are doing everything that we need to do internally. And again, that conversation's been had. The key bit and the thing that's happening, and in fact on Monday for us, we're moving the TOC back onto site. Our particular position, our particular the TOC estate opens on Monday, and we have been out and had a look at Blackpool and how that runs and bringing all the lessons back there. And actually some of our team are liaising with Wirral, who also perform well in the TOC area. So I think that's going to be one of the key issues, Tom, to maintain performance, and I think some of it you can see it in a lot of the metrics, the improvement, this sort of long length of stay with 7, 14 and 21, and then that improvement, as I reported, on the time to discharge, particularly when the patient's going to nursing or residential homes. So some assurance there that this will be maintained.
Did you want to say anything about the antimicrobials?
Oh, yeah, sorry, I forgot about that. Yeah, no, absolutely. So I think this links to us in terms of antimicrobial stewardship and performance around delivery of antibiotics. That sort of links to our performance around 60-minute treatment and triage. That's how we manage that in the ED in Aintree. I don't know if Nat wants to add anything on that perspective. Is that what your hand's up for, Nat?
Sorry, I was going to answer the other one, but you've answered it, Pete. Sorry, I'm not. Okay, I'm not cited on Aintree sepsis. We're at 71%, Tom. Yeah. I know the query previously was that the Royal was only at 40 something, wasn't it? But we've clarified the data, so ours is an accurate reporting now at the 71% at the Royal.
Aintree is a fantastic 100%, which is brilliant, but I can't believe the clinical difference is actually so marked. I think there's something under how we're reporting this or detecting it.
It's okay, Tom.
Okay. Just take it away. So I didn't really want to say much, but that's our position is reasonable at Aintree. But let's take it away and have a look and make sure that data is accurate, because it needs to be accurate for putting in the IPR.
Yeah.
Okay, thank you. Do you want this to go on the action rolling log so that we can have a better look at it? If you're saying yep. Yeah, would that be okay? I just think it might answer Tom's questions a bit more if we have a bit more of an in-depth look at it. Thank you. David?
Yeah, thanks, Jackie. And thanks, Peter. It's an excellent report and some really good progress being made there. But you mentioned that on pay overspending, you expect the substantive posts to have come down by the autumn. And that's great news. But it does leave a gaping vulnerability in bank and agency staff. And I read of other trusts who have effectively banned agency staffing and made significant savings through that. I just wondered, is that practical? Is that something that's being considered, or would it have safety implications?
So again, Dave was waving at me. Do you want to say, David, around the nursing position? I can come back on the Aintree position.
Yeah, sure. Thank you. So we don't use agency for any non-registered staff, and we haven't done for a couple of years now. The only areas in the organisation that we do use agency nurses are within critical care and within the emergency department, and we are focusing the attention now around how we move that to bank. But you'll know that there's also the issue around the current bank pay situation across Cheshire and Merseyside. About everyone's now at a midpoint salary. Rather than where they were previously. There is obviously that continued pressure around reduction of agency spend, and that's a Cheshire and Merseyside project as well. So there's projects on reducing agency use and the use of overtime. So it is something that we're all looking at to take a unified approach, so that one organisation isn't doing something more attractive to the bank and agency worker. And then whilst maintaining safety.
Thank you, David. And so from an Aintree position, that's exactly what we're following, is that's what we're doing across the trust. And we've moved that midpoint bank, which is reducing that bank pay. The risk obviously always was going to be, has agency increase in those critical areas, and we haven't seen a significant increase in that, so that's reassuring.
Okay, thank you.
Thank you, Sue.
Yes, I just had a general question around the ward closures that are planned, because they're sort of quite key to our financial performance and the delivery of the SIP schemes. And I just wanted a bit more assurance around the scale of that, timescales, and the risk mitigations that we have in place.
Yeah, so that's fine. So that sort of links to the question, I think, about the no criteria reside reduction. So those are the targets in place. Monitor that allows us to close the wards. So far we've closed 2 wards. One was not a CIP scheme, but it was a pressure. It was a Windsor ward, so that closed. I think when probably end of April. Then Ward 17, which was a substantive ward, closed in June. We also have taken down the temporary escalation spaces in our ED Surge 1, Surge 2, so they have reduced as we're seeing the no criteria reside numbers come down. The future plans there is another ward in this CIP, which is due to come out in September. And currently we are reducing the corridor. There's 15 patients on the ED corridor, and that's planned to reduce through August. So those are the sort of the trajectories of what we're doing over the next couple of months. So it's the corridor and another ward is in the CIP schemes.
Okay, and how many beds would that be roughly in this financial year?
In total?
In total, yeah.
Yeah, I think it's around 90 to 100.
Okay, that's great. Thank you very much.
Thank you. Pete, is there anything you wanted to say on your hospital transformation board? Because it's good to see it all coming together in the hospital sites, but is there anything you want to bring to our attention on that?
Not specifically, Jackie. It's overall rated green at the moment. There is 4 risks sitting at 12 within there that are in the paper, which we're working through. Some relate to making sure we're getting data around the capacity demand planning required, particularly for ENT and orthopedics, which we're working with the teams on. But those risks are being actively managed, and overall the transformation plan is rated green at the minute.
Thank you. Okay, if there's no more questions, are we happy to move on to the Royal? Yeah, Natalie?
Yeah, so if I just start with matters arising in the meeting. So just to touch on palliative care. So we referenced previously that Marie Curie inpatient wards that largely supported the patients at Royal and Broad Green are not open. So we have met with the ICB, and we have submitted a proposal to them this week with a costing that we could potentially stand up an interim solution on the Broad Green and Heart and Chest site, which would see us supporting 10 palliative care inpatient beds ahead of the winter period. So we discussed that at HMB. We're supportive, particularly of the clinical need for this, because at the minute the patients are spending extended long length of stay on our wards at the Royal, which is not the appropriate place for our end of life patients. So I will update next month on the outcome of that, but there is a meeting scheduled with the ICB next week to get feedback on that proposal. There was also an SBAR presented to HMB around a patient incident we've had around a patient that was seen in outpatients during COVID. A lung nodule was found on the patient, and it would appear the patient was not followed up for a scan and has then presented to the ED with progression of lung cancer. This follows a further incident I've had in another specialty around manual processes around outpatient referrals and the follow-ups. So it's really just a note today that we are looking into those incidents, and I'm going to pull together an overview of that to take a detailed briefing to execs, and then I'll be able to report back at next month ARC on the actions we're taking in response to those incidents. The other point to note was we also got presented an MIAA audit that we've had undertaken at the Royal site. So in our staff survey feedback, there is some comments around our recruitment processes and the ability to progress in the organisation. And I had some freedom to speak up themes emerging around recruitment processes and concerns around them. So we asked MIAA to undertake a recruitment audit for us, and it's come back with limited assurance on some of our processes. We went through that at HMB, and there is an action plan in place which will monitor through our people and OD group, and we are going to undertake a further audit of those processes in September, where hopefully we'll be able to get assurance that we have improved on the items that they found. So again, I'll be able to provide a further update on that following the next audit in September. And we've already touched on the ambulance handover 45, drop 45, but we went through that. So if I just move on to the KPIs and the performance, I'll just split it into themes. If it's okay, Jackie, I'll just take any questions on cancer, but I assume we've already gone through the cancer side of things in detail. From an urgent and emergency care perspective at the Royal, largely positive, really. We met 78.2% of all types performance, so we've met the national standard. That has continued in the following weeks. From a 12 hours perspective, we're at 15% in May, but again, that has continued to improve. Just touching on Jeffrey's comment, we are the lowest in a positive way in Cheshire and Mersey. Just last week, we were 9.1% for Luft on 12 hours. So we are seeing some real improvements on 12 hours. Our not meeting criteria to reside has improved significantly at both the Royal and Broad Green, and you can see that in the IPR, and we're maintaining that. And at the Royal, we've got the lowest 7, 14 and 21 days length of stay we've had in nearly 3 years. So we are seeing some real improvements across our length of stay metrics. We are in the IPR showing a 34-minute average ambulance handover. Again, that has improved and we're currently at 32 minutes. So generally seeing an improving position. When I come onto Transformation Board, you'll see that's enabled us to de-escalate the amount of patients we have on the ED corridor, and we've transacted the CIP in relation to that. And from a bed perspective, we shut 6 beds on 6B, which was one of our acute wards where we had medical outliers. So we've been able to remove medical outliers from that area. And this week we are closing an 8-bedded area on 6A, which is one of our medical wards. And by the end of August, we will have shut some beds at Broad Green as well. So we are on track to transact the bed closure plan, which is in our CIP plans. Then moving on to elective, really strong performance across Royal and Broad Green. So we have no 65-week waits, and we are now below the 1% standard for the 52% percentage. So we are meeting the 52-week wait target that we've got for the end of March. The only pressure point we really have in that is dermatology, as we touched on before. You'll see in my Transformation Board update, dermatology is in there as a sustainable service improvement. We've had a really positive appointment last week. We now have a nurse consultant and a GP with a specialist interest who are both starting in October. So we are just, I've just enacted a short-term plan to bridge to October using some additional capacity and insourcing, which we will just need to keep us maintaining that 52 and 65-week position to October. And then I'm more confident we've got a sustainable plan with the new appointments. And DMO1, which is our 6-week diagnostic standard, we're showing, again, we've maintained 5.71% in the IPR, but the latest position now for the Royal is that we're meeting the 5% standard. So again, we are on track to meet the national target for that. So generally really positive improvements across the elective pathways. Moving on to risks, we've got 20 risk scoring a 12+. I'll just touch on, we've had 1 risk increased in month, which is around the cleaning standards and the IPC measures. You'll see the CDT cases did come back down in the IPR, but we have got ongoing concerns around cleaning. This is both, to be fair, this is both domestic support because of the level of vacancies and sickness we've got, but also IPC practice with our clinical staff. So we've got a dual action plan. So there is recruitment ongoing to all domestic vacancies, and we're using bank to support while we recruit to those. And we have got an action plan and a comms plan with ward staff around our expectations around IPC practice. Once we start to see the improvement in the cleaning standards audits again, and we get the recruitment trajectory and start getting those posts in place, we'll be able to reduce that risk. There are 3 new risks scoring a 12+ at the Royal. One is around admin resource, particularly in the surgical division. So some of this is the vacancies and ongoing sickness, particularly in medical, and the impact that is having on our typing turnaround. We have got action plans now in place, and we're looking at moving staff between specialties, particularly to support urology and general surgery. I'm getting side to those plans this week, and once we can see that and we can see the typing backlogs coming down, I'll be able to reduce that risk, but we just monitor that closely. We also at HMB had an update. Our ophthalmology laser, which we use to treat our cancer patients, has broken. We have approved the purchase of that through our capital equipment programme, but since HMB we have now got an interim solution in place, and we have loaned a laser from the company whilst the purchase is progressing, so that risk will be removed. And then the final new risk was 8936. So this is the risk raised around the fact that Royal is so reliant on additional lists running at a weekend, particularly in neurology and gastroenterology. That has had an impact on us with our activity levels for the last couple of months. So we are maintaining the position, but we are struggling to meet our activity plan because of the weekend operating. Again, urology and gastroenterology are the two areas that we have approved the business cases to get the sustainable solutions in place, so we don't need to do weekend operating. And when I come to Transformation Board in a minute, I can update on the positive progress there. The other risks are all continuing risks that you've seen previously, so I'll just touch on the changes or the progress we've made. I've already mentioned dermatology and the successful recruitment. Paediatric dentistry has been a risk we've had on there for a long period, but we have worked with the university and we have changed the job descriptions to try and make them more attractive to candidates, and we now have 3 candidates scheduled for interview in September, so we're hopeful we'll get some successful recruitment to substantive posts. And 5437, the mental health risk in the ED. The work that the ICB and particularly Mandy Nagra and team have been doing with Merseycare means they've put some new escalation protocols and pathways in place. And although we are still seeing long waiting patients, we have seen a marked reduction within the emergency department at the Royal in the last couple of weeks. So the risk remains because it's early days, but we are starting to see some really positive traction around the mental health pathways, which I'm hoping is going to continue in the ED. And then 7413, which is the risk around the diabetic foot pathway. We have now undertaken the review. I've seen the latest statistics across the sites, and there is definitely a case of need for additional support needed around podiatry. That case is coming to my HMB in August, which I'll be then looking to support and get the support in place that we need to improve that patient pathway. So if I just move on to the finances, the Royal is 2.6 million away from plan year to date. Similar to what Pete said, that's largely around CIP underachievement because I'm 2.7 million away from my CIP plan year to date. And again, the largest proportion to that is really in relation to pay expenditure. We did see really positive in June that the Royal have reduced 67 whole-time equivalents in month. That is largely bank and agency at the Royal. And if I come back to our strategy, that is because we are investing in neurology, gastro, breast. We are putting substantive workforce in place to reduce the reliance on the bank agency and insourcing. We need to go further, but obviously in month, the next ward, as I just said, 6A is closing and Broad Green will reduce. So I am expecting further schemes to come online. Similarly to Pete, we have met the 75% of schemes are now fully developed. However, I do have a proportion of 8 to 9 million of my CIP plan, which is still at risk and still rated red. So when Rob comes on to the financial risk overall, you'll see where that plays into the overall positions. But that's my focus really, is I still have a significant proportion that I need to try and get to green. And just touching on Transformation Board, so in breast we've had successful recruitment to some of those key radiology posts, so that's helping us get a more sustainable position, which I've touched on, that we're at plus 80% on the faster diagnosis standard now in breast. Gastro, we approved the business case. We had a recruitment day and we are fully recruiting to all nurse posts in gastroenterology. We had a really good uptake around endoscopy nursing. We're now just mapping the timeline and the financial savings trajectory for those staff to come into post. And then urology, we approved the business case and the team are just working on the adverts and getting those all out on track so we can start the recruitment to the urology. We have added dermatology into our sustainable services plan because I was concerned around the additional capacity and the reliance on additional support for dermatology. So they're just working up their plan, of which getting a nurse consultant in post, which is now scheduled for October, was part of that plan. UEC, I'll just touch on, we are introducing a surgical assessment unit to the site. We've been doing estates work and pathway mapping, and that will go live in September ahead of the winter period. I am really hopeful that will have a significant impact on the 12 hours at the Royal, particularly for urology, where we struggle with long waits in the ED. That will be a 7-day service and should have a really positive impact on patient pathways. And in dental, our digital dictation has gone live with positive feedback from clinicians in months. So we're just looking at where we can make then financial savings against some of that digital dictation improvements. We have introduced nurse-led clinics in restorative dentistry, again, which is improving our capacity offer in dental. And the final bit on dental, we touched on previously the risks around the changing model of potentially the dental contract and how the community provision would work. So we're undertaking a full review around our financial sustainability plan with dental and trying to remove what is the university funding and what is service funding, so we can really understand those risks. And we're getting that presented to next month's transformation board, and then we can take action based on what that tells us next month. So I think, sorry, Jackie, that was a bit long. There was a lot to update. That's everything for the Royal and Broad Green.
Thanks, Nat. I think, you know, everything that we've got to share at this point is really important, and it's the heart of the meeting because this is where we're getting our assurance from. So please don't apologise. It's fine because other sites may not have as much to say. So that's fine. OK, then questions for Nat. Jeffrey.
Just to share some feedback, really, Nat, really good report. I was meeting with Raj Jain a couple of weeks ago, and he said that the Royal is without doubt the best performing acute in Cheshire and Merseyside. So well done.
Thank you. The team are doing brilliantly.
David?
Yeah, thanks. And a really good report, Natalie. There's some great progress being made there. Well done. And just one question from me, and apologies. I fear I may have asked you the same question last month.
That's fine.
But the touch time utilisation in theatres, the uncapped touch time falls a long way short of the target. And I just wondered, the report says that requires targeted actions before the target can be delivered. Just wondered if you could say something about those actions that are planned.
Yeah, so I think, David, you're referring to the Broad Green uncapped touch time, I'm assuming, because that's the one that's got...
No, it's on the Royal site on page 120 of my pack.
Yeah, so the uncapped is a lot higher, isn't it? And the capped touch time is lower than we would like. So we're doing a lot in overruns, and what we need to do is a real concentration on start times and full utilisation of the list. Now there is a whole theatre, I forget, it's TPIG is the acronym for it. There is a whole theatre improvement programme around improving that utilisation, which we're working through, and that's coming through Beth's corporate ops group. So there is a structured plan in place, but accept there is further we need to go on that, and that is an area for improvement at site. From a Broad Green perspective, you'll see that is worse as well than the Royal. Now, some of that is the complications of Broad Green hosts the services, and it's part of Pete's orthopaedic improvement plan in his transformation board that he's focused through there on trying to get more cases on each list.
Thanks. So when would you expect to see the impact of that work coming through and improving in the reporting?
So if it's okay, Dave, do you mind if I just bring Beth in, because Beth's overseeing that programme with the sites, if I can just let her give the update from the milestone plan? Is that all right, Beth?
Yes, Beth.
Oh, do you want me to come in? It's just I don't want people to think I'm out of sequence with the hands. Okay, so David, there's a range of actions, and the actions vary across the sites. So we have some overarching improvement programmes focusing on booking and scheduling, digitising, pre-op assessment, etc. And the more local initiatives are around the start-finish times, how we communicate with patients, etc. So it's a range of different actions that we're focusing on. There has been significant improvement across all the sites who have theatre champions. We've had people from the national team come in and work with those champions to make those improvements. In response to your question around when do we think we'll be at the required standard, that's difficult to say. What we need to make sure is that we are seeing the improvement month on month. We do see a dip over Christmas, so you will see in the IPR that we did see a dip over Christmas, but then month on month we're seeing those improvements, and we need to carry on with the actions. Once we stop seeing those improvements, we need to refocus and make sure that we are focusing on the right things. We would like to think by the end of this financial year we are there or thereabouts with the required standard that we've got.
Thank you.
Thanks, Beth. Tom?
Thanks, Jackie. Thanks, Natalie, for a great report. Two left of field comments, perhaps. The first is the comment in your report around the performance assessment framework. And after all the hard work we've done, I think I'd be disappointed to end up in segment 4, but maybe you can comment on that. Maybe that's the way the metrics lie.
Sorry, so that was just a comment at the HMB. We were just looking at the draft, so it's not been released yet, Tom, so we probably just need to wait until we get the formal report for that.
Okay, thank you. And my second one is around a risk question, really, because we haven't touched, and it's across both sides, we haven't touched on the junior doctor strike yet and how we managed through that. So can we have a comment maybe from you and Pete on how we got through that?
Yeah, so we did a debrief on that, Tom. So there were no, from our perspective, there were no sort of significant concerns as in managing through that period. We managed it well. I suppose the issue is obviously the financial impact of the industrial action, and obviously the coordination of trying to ensure minimal cancellations and changes to patients. So from a Royal perspective, our biggest area really is critical care capacity and how we try and maintain that capacity throughout the industrial action. So, but teams worked really well and no significant issues over that period of those 5 days.
Pete, do you want to come in?
Yeah, happy to just drop in, say, echo that completely. Well planned, no significant patient safety risk throughout the period. We did try and concentrate on not cancelling urgent cancers, P1s, P2s, and we didn't at either site. So that's also a positive, Tom. That's not saying there wasn't cancellation. So that's Nat's point about what then is the impact from a performance perspective and a finance perspective on that, and we're working through that now.
Jenny, is there anything you want to say about Liverpool Women's?
Yeah, thanks, Jackie. Yeah, similar position really in terms of no significant issues reported. There was a financial cost, as you would imagine, which was circa 150k for Liverpool Women's, which we've managed to absorb. So all in all, you know, we got through okay. It's just having a look as the others are in terms of anything that was cancelled, and there were no urgent or cancers cancelled, but what the impact is of that on the elective position moving forward.
Thank you. Sue, you've got your hand up.
Yes, just a quick one. You mentioned that you are behind plan by about 2.6 million, and that's partly largely due to the CIP. Do you see that being recovered during the course of the financial year? That's one point. And the second point is around the SIPs. 75% of those having been worked up so far, being green and blue. Are they recurrent? It's a large proportion of that recurrent, so just 2 points.
Sorry, yeah, so sorry, 75% has been worked up, is fully developed, 25%
right.
It hasn't. So so we've transacted 14 million so far this year, of which 13 million is recurrent. So nearly all the SIP that we are transacting is recurrent, and the projected forecast is to continue at over 90% recurrent. At the minute, no, my forecast is showing I am forecasting an issue of 8 to 9 million on the CIP at the minute because of remaining in red, because they're not fully developed. So I've got the 2.7 million at the minute in effect. That's continuing. Obviously, I'm working with the teams to look at how we can try and bridge that, but there is a risk at the Royal that I don't currently have a fully developed plan for the full 34 million.
Okay, so we'll keep an eye on that.
Yeah.
Okay. Thank you.
Thanks, Sue. If there's no other questions, Nat, can I just ask around the palliative care 10-bedded facility that you described as Marie Curie previously? I'm just wanting to be assured, because obviously there's many more patients that are palliative care and end-of-life care across the organisation. How are you going to, if we're to take it on, how are you going to ensure that we don't have any inequity for our patients, because we can't afford to let some patients have a better experience than others?
Yeah, so we're working through at the minute a clinical model of end of life care, Jackie. There's a first meeting on Friday at Place, so we're going to be looking at exactly that. What are the different services and in-reach models available? So they're looking around the virtual ward for palliative care as well. And Marie Curie are still continuing with the outpatient and ambulatory side of things. I suppose at the minute, the issue is we've got Woodlands Hospice on the Aintree site that we utilise and we have for the patients. But at the minute, the way it stands, and it has done for the last few months because Marie Curie have been slowly reducing their beds, is we have no provision to the patients, particularly on things like the gastro wards. They are just in our rooms. So at the minute, the first step would be to stand up some beds to give a dedicated space to support these patients and their families. But running alongside that with the ICB, they want to stand up with us, a group, to review the whole palliative care model and offer for patients. And I think that would pick up exactly what you're saying. What is that holistic approach to palliative care? Julie Bellew is our palliative care clinical lead, and she's part of that group on Friday who's trying to work with and advise what we need to do for our patients, because they want to review the whole service.
Oh, thank you. That's really helpful. David?
Thank you. Yeah, I think it's fair to say that at least for the last year, it has been inequitable across the city because Marie Curie haven't had any inpatient beds in the south of Liverpool, and so there hasn't been any inpatient provision at all. I think what this initiative will do is it'll give us greater opportunity to level out some of the equity. I don't think it's going to be an utterly perfect service right from day one, but we will be working towards a more equitable service across the whole of Liverpool, Knowsley and Sefton. But you know, this is the first step into it, and I think it gives us greater opportunity for the voices of the palliative care service in the group to help lead on that.
Thank you. James?
Yeah, just to note that obviously it's a commercially sensitive conversation because this is about the commissioning of services from Marie Curie and the future of that. But as has been said, this is the end of life model review is clearly required anyway. But this would be about the trust stepping in to provide something that was additional and extra that was previously provided by Marie Curie if it's contracted. So there's still an issue of the ICB would need to contract the service from the trust for us to be able to do that. It won't be about the trust stepping in and providing additional beds at additional cost for something that's been removed. It's got to be appropriately contracted. So there's a commercial conversation obviously going on alongside that, which obviously David and Nat and Jim and others and Peter are all involved in.
Apologies, I probably didn't make that clear. So the bit we have submitted at the minute is a short-term temporary issue for us to support with, and then, as I say, there is a longer-term contracting and commissioning plan, Jackie, around the palliative care service longer term.
Right, thank you. Because I know in the past Liverpool's attracted a lot of attention around end of life care and how it's described and what we do. So I just want to make sure that's all captured as part of that process. Thank you. Okay then, so if we've finished there, can I ask Jenny to talk about Liverpool Women's Hospital?
Thank you. Thanks, Jackie. So I will take the Executive Managing Director's report and matters arising from the perinatal dashboard and maternity incentive scheme together. So a few things to draw out for Liverpool Women's. The first being the financial position. So Liverpool Women's reported a year-to-date deficit of 4.8 million at month 3, which was on plan. Our full year plan is a 15.7 million deficit, but I'll remind the group that includes non-recurrent deficit support of 15.3 million, and actually at month 3 our underlying deficit was 32.4 million pounds for Liverpool Women's. At month 3, in terms of our pay expenditure, we were about 300k overspent year to date, but under on non-pay. Early indications at month 4 tell us that this is improving, and I mentioned before the industrial action costs, which we think we'll be potentially able to absorb within that position. So we're moving in the right direction on pay. Cost improvement plan was 2.1 million year to date, of which 1.3 million was recurrent. And we know that one of our risks to CIP will be the recurrency of the identified CIP as we move through the year. The overall forecast for CIP remains on plan at 12.7 million, which is circa 6.3% of our total expenditure, and 10.7 million of that is forecast to be recurrent. We meet weekly as a CIP portfolio board as part of the transformation board to monitor that progress, and there is some really steady progress on that. Liverpool Women's position in terms of the amber green is 70% at the latest position, but we're moving towards the 75 quite clearly. Concern of Liverpool Women's in relation to cash. At the end of month 3, that was 4.6 million, but we know that as we move into coming months, we will need additional cash support to move forward. If I go on to the IPR and performance, similar position for Liverpool Women's as in previous months, but just want to flag deterioration in the FDS, the faster diagnosis standard, to 61%. We had previously, if you remember, been reporting an improvement and exceeded the 75%. And we're still improved from where we were, but not to that level. So Beth's central ops team is supporting us with this, and the 62-day, which you'll recall, which has also deteriorated. We know we've had high referrals, but corporate ops are backing around us in terms of some of that improvement plan that we need to put into place. But in that, on that, there is some good news in that the ambulatory build was handed over this week to us. You'll know that we've been putting on that extra capacity. So that will give us an additional 25 procedures per week through that additional capacity, which is funded through the business case. We've talked in the past about perhaps accelerating some of that, and that's just conversations that are still ongoing in terms of do we put on even more capacity, but we know that at the moment that is not funded. And just to flag as well from the IPR that our PDR compliance has reduced. We are introducing group PDRs for those people who have a number of staff that they need to perform PDRs and appraisals for, in terms of doing those more collectively rather than individually. So we hope to see some improvement from that. Also, just to flag, we had a conversation at the last ARC in relation to staff fill rates. I have included some additional information in Appendix 2. We've done some detailed review at the hospital leadership team. We'll look at where we are in terms of the safe staffing report that you'll see coming through, but fundamentally, we've got no concerns with the staffing in the service. Obviously, a high fill rate, which ideally over 90% would be where we would aim for good patient needs being met, and obviously the opposite, over 100%, we would be thinking perhaps we are overstaffing. But I think the things just to note for Liverpool Women's are we do a dynamic review every 4 hours on staffing, and what we see sometimes in some of the areas is that as the acuity switches, the staffing levels will switch, and that's not necessarily reflected in the metric that the IPR counts. So just to highlight, there are no concerns in this area, but all the detail is in the appendix. If I move on then to the high risk register, there are no new risks to escalate. We have seen a slight decrease in score in the pharmacy and meds management risk as recruitment is underway, and we expect that to drop further as the business case is implemented. One of the focuses at the meeting of the Hospital Management Board was our isolated site risk in the context of the board assurance framework and the corporate risk register. When we were separate organisations in terms of our BAFs, the isolated site risk was a key risk on Liverpool Women's BAF. It forms part of the wider group BAF now. So what we want to just make sure, and we'll probably do through the Hospital Management Board, is make sure that this group is cited on the issues in more detail through the isolated site, and potentially through the corporate risk register as well, which Claire, I'm sure, will mention later. But we had a really good conversation around how we keep that dynamic and moving as we move forward. And also the joint risk register, myself, Nat and Pete are comparing our risks in terms of the fact that we don't always have the right services where they need to be, and in terms of the in-reach support that we give each other, and making sure that our controls are aligned and that they're working in the way that we think that they are. And then just two things to draw out from the maternity reports. Subsequent to the Hospital Management Board, the team raised a concern in relation to the Safety Standard 7 and around the guidance that mandates our MNVP, Maternity Neonatal and Voices Partnership representatives to attend local PMRT sessions, and they have raised a concern around some of the sensitivity of that in terms of having those representatives at each of those reviews. It's been escalated to the LMNS, the local maternity neonatal system, and they've raised this with NHS resolution as well. So they're just flagging that to us at the moment in terms of compliance with that, as they're not sure that it's an appropriate request in terms of asking our representatives to attend those sessions. So I will report on that in full next month when we've been through it. And then just to also note that the Trust received an additional £138,000 in relation to the maternity incentive scheme, which was the share of the amount which was left from those who didn't achieve. That's lower than previous years, but nevertheless does support the investment already made in maternity coming into the organisation. So I think I will pause there for any questions.
Thanks, Jenny. Any questions for Jenny on that? David?
Yeah, thanks, Jenny. It's a clear, very clear report, and well done for the progress that's being made. As I still feel a relatively new NED at Liverpool Women's, and the reference to 173 recommendations from national reviews is a bit scary. Well, no, it's a lot scary. I just wondered if we could, a future workshop, set aside some time just to do a deep dive into that and to understand which ones we should be prioritising. You can't do 733 recommendations all at once. But you know that there will be some important things there that we should be focusing on, and I'd find it very helpful if we could spend some time at a workshop just going through that.
Yeah, absolutely, David. And that was something. There was a national event a couple of weeks ago, which I attended, and that was where that was raised in terms of the maternity and neonatal investigation work that's happening that we talked about last time. And I think there's a recognition that there's already 703 recommendations on the national database and another investigation about to take place, which will conclude in December, and then there'll be a task and finish group after that. So I think part of that investigation and that work that's going to happen in the run up to December will kind of address the fact that we've got all these recommendations, but they're not necessarily making the difference that they're supposed to, and how do organisations and boards manage all of that through, and how do the teams manage all of that through going forward. So I think you're absolutely right. I think hopefully the investigation or transformations that's being called now will resolve some of that and make that a bit more streamlined, because it is a very, very complex environment. So absolutely we can go through those in detail.
And hopefully in that discussion you'll tell me we're already compliant with 730 of them, and then I'll start sleeping at night again. Thanks, Jenny.
James?
Thanks. It wasn't a question. It was just, Jen, I don't know if you just, obviously we can't talk about the content, but if you just want to update ARC on where the CQC inspection report process is up to. Yeah,
so we've had the draft report back, which we have been through for factual accuracy and sent back to the CQC. There was not a lot that we needed to update or amend in it. It remains a positive report, and we will get that hopefully back as a final in the next week or so, and then we'll be able to publish it and talk about it in more detail.
Thank you. Okay, if there's nothing else, shall we move on to Diagnostic Treatment Centre, Beth?
Thank you, Jackie. So the DTC, there are 7 12 plus risks. 4 of them are associated with financial risk and 3 associated with workforce risk. The things I wish to pull out of the report this morning, 2, and then I'll move on to finances. 1 relates to genomics. The contract, we have received notification from Manchester that they wish to cease the contract with us from the 31st of March 2026, which will have an impact on workforce, equipment and the financial position. A task and finish group will be pulled together to work through the safe transfer of the service, but this is as a result of the commissioners who wish to commission the service in a different way moving forward. The second, there's always risk associated with any inspection, and so I wish to pull out that on week commencing the 21st of July, we had 3 inspections. One was from the MHRA transfusion service. It was unannounced with 4 days notice, but it was classified as unannounced. Next was the accreditation service in microbiology. That's an annual inspection. And finally, the HTA mortuary, which was the first unannounced visit that we have had. And I'm pleased to report that the verbal feedback, we have yet to receive the formal reports, was that there was nothing that they were concerned about. So that's really positive for the areas that were inspected. And I'm hoping that when we do receive that report, there won't be any risks associated with the outcome of that. The other thing around risk, we've had risk associated with culture engagement, particularly in LCL, and it's just to report that I had my first engagement session with staff yesterday. We had a relatively good turnout, and I've already had people reaching out to me who want to come and meet on a one-to-one basis, but it was positive, and I think that people are keen to embrace change. So I just thought I would mention that. The final thing I wish to pull out of the report clearly is the financial risk, and you will see that for all the areas, pharmacy, imaging and LCL, they all have a 12 risk noted for finances. The position as at month 3, we are £370,000 behind plan. Income is up by 1.7 million. Expenditure is, though, a deficit of 1.3 million, which is what's driving the £370,000 position. Pay is virtually balanced as at month 3. And from a CIP point of view, our CIP this year is 9.2 million. 6 million has been identified as and categorised as blue and green. And from a month 3 position, our target was just over 2 million, and we've transacted 1.5, so 75%. From a headcount point of view, we are managing through vacancy freezes that headcount. We have seen a reduction, and we are just working through some numbers. We have seen a reduction, but as I say, our target is 151, but we have 151 contracted whole-time equivalent vacancies. So that again is work in progress. Thank you, Jackie. That was all I was going to pull out the report, but happy to take any questions.
Thank you, and really good outcomes on those inspections, because they are difficult and we've had issues in the past, so that's really positive, that update, so thank you. Any questions for Beth? Tom?
Thanks, Beth. It's great to see some pharmacy metrics in a way we haven't seen before, and obviously there are some concerns in there, but it's a good start and gives us a baseline, so we need to keep working forward on that.
Okay, and David?
Yes, reiterate Tom's comment on pharmacy. The other thing, at a previous meeting, Beth, you told us about the difficulties with pay comparators that other laboratories in the area, against ICB guidance and against their agreement, were paying premium rates for staff retention that we weren't. You were going to talk to the ICB about that and try and resolve that. Have you any progress on that to report?
Okay, thanks, David. So they haven't resolved it, but it's certainly been it's on their radar, and the inequity across the system. There's a number of changes that we expect to make. There was always a plan to have 3 laboratories across the system. I think they are reviewing that with a view to maybe having 2, because obviously there's more focus and scrutiny on the costs. So yes, it is on the radar, but not resolved yet.
Is it something we should keep on the action log to keep an eye on, perhaps?
It is on our action log. So in the DTC management board, we have a number of things. We are looking at the 24/7 service. Is that something that every lab should do? Is it something we can do as a system? There are a number and a range of actions that we're looking at, David, within our management board, and you will see that come through via the assurance report when there's updates that we can give.
Right, thank you.
And just to say, in response to the Tom comment, it is a big thank you to the BI team and also the performance team for pulling something together for pharmacy. We need to, though, make sure that the metrics are meaningful and also that the exec MDs on their sites also have visibility of that when we've got it right. So anything that is pertaining to your sites, you will have, I think, more visibility on than what you've had previously. So thank you.
Thank you. Tom and then Sue.
Mine's a totally different point, so maybe Sue wants to come in first.
Mine's a completely different point, but it's very quick. It was just really good to note the cultural and teamwork that's taken place in terms of improving sort of staff concerns. So that's really positive. Do you see any sort of significant work needed going forward to maintain that?
Yes, it is significant. The cultural piece in LCL is quite far-reaching, but we're starting with basics, and that is about open, honest, and transparent communication, and that's how I ran the session yesterday. So this is not going to be something which I can turn around in quarter 2 and 3. I think this is a plan, but I want to kind of co-design the content of that programme, which they are keen to be involved with, and I would like to think that within 12 months we will be in a different position. That's what I'm keeping people focused on. We would like to think that we're in a position of strength, and the people that have reached out to me, and I'm going to make myself available in my office because some people felt a little nervous talking openly. I'm going to try different communication methods to get to the bottom of what people are concerned and worried about, because without that we can't put together a meaningful action plan.
Okay, so sort of over the next 12 months, we'll see further improvements. Okay, thank you.
Tom?
I think we're about to leave the IPR, so just before we do, one last comment. On page 147, the shimmy for Broad Green, it isn't really 73, is it? There's something bizarre happened in the papers there. Maybe we can fix it for the permanent record.
Sorry, Tom, which have you seen it, Joe?
It's on page 147 in my pack. It's the shimmy there. It's recorded at 73, 72.9 or something.
Sorry, I should have said that on the, yes, I've picked that up. I think that is a data reporting issue.
Thank you. Excellent. James?
Yeah, given Broad Green features on the Newsweek list of the top 200 hospitals based on its mortality rate being so good, it is an error. You're right, Tom. We'll just pick that up and correct it. Apologies for that. It was only just to say, Heather and I had met with staff side and a few other colleagues as well earlier in the week, not about LCL, but just more generally. But LCL obviously features heavily. I know the board have been always for the last, well, certainly 3 years I've been here and before that, LCL features as the sort of the worst outcome in our staff surveys routinely. I was encouraged by the signs that there's willingness to work differently, and that there's staff side feel that there's a genuine desire to do something differently. But you can't underestimate the difference between the sort of the top and the bottom. It's a poor descriptor, but of that organisation, there's still people who are working on the shop floor, if you like, who have mistrust in everything that sits between them and the people at the top, and that's where we really need to get into. So I know what Beth's describing is that sort of open, honest, we'll answer your questions, we'll be clear on the answers, but it's going to take some real time. That we found in Luft, it took at least a couple of years to start to get people to feel like if they said something, it was heard. So I think we're seeing that turning a corner, which is brilliant, but it will take some time. It's a real challenge for us. So, but really good positive start, I think, with LCL.
Okay, we're happy to move on. Yep. Okay then. So we've got Claire Alexander joining us for the risk management approach for UHL Group.
Thanks very much, Jackie. Good morning, everyone. Just to note, I wasn't planning on going through the information I've sent slide by slide because you've had the information as part of your packs, and I hope it's relatively self-explanatory around what we're trying to achieve. I think it's fair to say that over recent months, we've had a number of discussions around our existing risk management approach, particularly within our senior management board. And our existing approach very much categorises risk by a corporate services risk register and hospital risk registers. I think Liverpool Women's joining the group led us to think that that existing risk approach was no longer fit for purpose as we grow. So anything we do now, we want to foolproof as we grow as the group. So we want to propose a different way, particularly in terms of our risk categorisation and our reporting, and it is in line with the NHS providers model, which was presented to us in a workshop. I think it was around May or June time, and I think most of you were at that workshop. So hopefully the information in the pack wasn't too much of a surprise in terms of where we want to go. I think it's important to note that our existing approach to date has taken us quite a long way. It's certainly made us more risk intelligent. And I think particularly, I would say around the sites, I think it's enabled us to address risk more quickly than we might have done before, because maybe we didn't have the visibility we needed on a number of those key risks. And I think I'm fairly certain, I suppose it's linked to visibility, that we're not hit with the surprises we potentially might have been 2 to 3 years ago. I think it's important to note that it doesn't undo any of the good work that we've done associated with risk. I see it as very much improving our risk maturity as part of our journey as a group. I suppose just to summarise, where we want to go more broadly is to categorise risk in 3 ways. So we would look at group strategic, group operational and site operational. And again, that aligns with exactly as NHS providers were, in part around how NHS providers propose a mature risk model for the group. I think a key element that we're going to have to work through is that we define the relationships between those risk categories appropriately. We take a look at the BAF and how those risks align with the BAF and how we manage those categories. But we also need to support the sites to understand when site risks that they hold potentially become group risks. So how do the site operational risks then become group operational risks? And we need to be clear around some of those definitions, which we're not quite there with yet. So this is very much around seeking I suppose, support to progress with this new management risk management approach. You'll see in the pack that we've provided a number of examples of where the categorisation may change for some of our existing risks. Jenny helpfully mentioned one just as I joined the call around the isolated Crown Street risk. I think that, essentially that's seen at the moment as a hospital risk. In reality, that's a group risk, and we need to work through how we view that as whether it's strategic, operational, those sorts of definitions we'll need to work through. But there are some examples there. I would note we haven't yet been through these with the senior teams. We need to do that to seek their views on that categorisation and where they would sit, but they were just to provide some examples. So if we do go forward with this revised approach, as I've said, we need to work with the leads to categorise our existing risks and what that would look like from a reporting perspective. We definitely need to consider the revised BAF and how some of those risks link directly, and the relationship between the BAF and the operational risk register. We'd obviously need to adapt our training because it is a change, and unfortunately I know you've just approved our group risk management policy. We're going to have to bring that through again, but we would do that probably towards the end of Q3, so it wouldn't be an overnight change. I would just note one risk associated with this new risk approach, and that's the fact that the hospitals in the group, so us and the Women's, and also that of the trust that are joining the group, so Liverpool Heart and Chest, are all on different risk management systems. So it's a risk we just need to recognise at this stage. There are plans to incorporate the approach to procuring a risk management system across those group of hospitals as part of the corporate services work, because it needs robust governance associated with it, and there are significant numbers of stakeholders that we need to involve. I think in the meantime, though, we can still manage to progress with the model within the existing systems that we've got, and it's about the reporting, and we can manage that in the best way we can, pending that approach to a new system. I think, Jackie, that probably summarises everything I was gonna say associated with it. And as I say, I hope the information you received was relatively self-explanatory. Thank you.
Thanks, Claire. Yes, it was very self-explanatory, and I think the workshop helped us as well in some of that thinking. You're asking us to proceed with the changes to risk categorisation and next steps to better account for the group model and site accountability. So before we agree that assurance, has anybody got any questions? David?
Yes, thanks, Jackie, and thanks, Claire. It's not so much a question, more of a request, really. You say there's going to be a senior team review of the categorisation of the risks as we go forward. Just wondered if, when that's done, you can bring the updated process and proposals through the audit committees. We've recently had some substantial assurance from MIA on our management controls processes. I'd like to make sure the internal auditors and the external auditors are in the tent on this, and they're fully signed up and understand where we're going, so we keep them on board. But that, it's great. It's very sensible. Well done. Thank you.
Thanks, David. Very happy to do that.
Okay, if there's no more questions, are we happy to support that recommendation? Yeah, getting nods. Lovely. Thank you, Claire. Thank you for your time.
Thanks, everyone. Thanks.
Thank you. Okay, then. So we're now up to the ARC reports from the group. James, are you leading this section?
Yes. So the corporate services report, the risk scoring for that was the key bit. Claire has already discussed the bulk of the paper, which is this move towards a sort of evolution of the way that we report risk. So we don't need to cover that. And I think the support for that's very welcome. There was two new risks that we wanted to highlight, 9100 and 8222, and that is around the finance department ability to continue to run efficient services because of vacancy restrictions, and the risks are in there. Rob will obviously be able to provide any context on this, but you can see that there's we're seeing this in a few areas. Vacancies being held, greater asks of departments, particularly in terms of reorganisation of corporate services, but the solution only comes when you've done that. So the solution is obviously the broader corporate service integration. So it's bubbled up into a 12 now, being managed through the finance team, obviously. So again, Rob will be able to comment on any adequate controls. And then the corporate ops risk, which was around the inadequate response to incidents, high-profile sites and events, and some of the learning around that, and that's come in as a 12 as well. And I'm sure Beth can take any questions on that one. Everything else is on there. There's an escalated risk, which was the estates and facilities one. That I think will start to reduce now because we had a lot of sickness and then also vacancy controls in place, particularly around facilities and cleaning. I think Nat touched on it before. I believe from my meeting with the turnaround director this morning that a number of posts have been approved for facilities to make sure particularly that area is well covered. And the remaining risks are residual in existing risks, all of them contained in the papers. Happy to take any questions on any of those, but the usual process of highlighting the key escalations, Jackie.
Thank you. Any questions for James? No? Okay. Is there anything you wanted to bring up about the Luft and LWH IPRs, or have we covered that earlier?
I think we've covered them through the site report. It's obviously there for information, so if there's any triangulation that people had, but I know Tom picked one up earlier, but if there's anything else, happy to take them now. Otherwise, they're there for assurance, Jackie.
Thank you. I'm seeing no hands, so I'm presuming everybody's happy. Lovely, thank you. Rob, it's over to you now for our Finance Month 3 and then the Financial Plan 25-26 and the PwC report. So you've got a bit chunky agenda. We've got half an hour left. So over to you.
Okay, thanks, Jackie. So yeah, there's a few items here to discuss. I think it might be wise, Jackie. So we've got the finance report and the Simon Worthington report. If I cover those through using the slide pack, I think that might be the easiest way to walk it through, if that's okay. So
yes, that's fine. Thank you.
Okay, great. If I just share my my screen. Can everyone see that?
Yeah.
I'll leave it in this format because I can then see you all if that's okay.
Yeah.
Okay, great. So lot to go through. Lots happening. Just to note, in terms of the month 3 report, the details are in obviously the finance report, and we do include detailed analysis for Luft, for Liverpool Women's, and we include the LASP position as well that we obtained from the ICB. So you can see that in context, but overall position as at month 3 is that we are on plan at the end of Q1 in both organisations. We have hit our CIP in both organisations and are ahead of plan. We've identified all CIP for the year in both organisations. So a good story, albeit that the risk escalates as we go through the year. So I'll start to talk on that now. But I did want to just talk about the progress. Again, I've highlighted, we talked about this last month. I'll keep updating where we have made good grounds in both organisations because I think it's really important. But I'll highlight where there've been changes. So again, at Luft, just noting that we're ahead of transactions year to date for CIP. The recurrent, if you look proportionately at the end of Q1, is ahead of its recurrent target with 36% transacted, and we've fully identified the plans at 119 million versus 117. Variable spend has reduced year on year, £3.1 million, which is good, albeit we'll come on to the risk in the plan in a second. The bed closures you've heard about on both sites, particularly Aintree to date, which again has seen WTEs reduce. So 197 since the start of the year, and budget removed as well of 215. So as key risks for us, there has been some good movement in those areas. Difficult decisions are being made, and we're collaborating with the system improvement directors on that and working as corporate partners. And the corporate service reconfiguration continues at pace. And just to note, importantly, I think in the finance world is that we've got a plan now to move all 5 organisations onto the same ledger provider. That's not one ledger for everyone, but getting us onto the same provider is the first important step. There's 2 organisations that are on different providers, and we aim to do that by the end of the financial year. So good progress in these areas. One item that isn't on here that I think would be welcomed by the board to note, or the committee to note, is that we had the resolution to the Saba dispute at the end of July, and I'm pleased to say that we won that dispute in its completely. So that's really pleasing that risk now dissipates from the organisation. So just to note that, which is a bit of good news. Progress at Liverpool Women's, very similar. And again, we continue to progress with the CIP, on track at the end of Q1, fully identified plans. Variable spend is reducing, as is WTEs, even though the overall plan for the year is to increase. And the non-pay remains on track at Liverpool Women's, and Jenny's updated where we are. So lots of good items happening and progress being made. However, we know the scale of the plan means that we've got significant risk. And again, we keep updating the run rate, which is the really important item for us. And as has been called out in both organisations, the big factor for us is pay, and the really heroic reductions that we need to make in WTEs to get that pay down. As you can see, based on the end of Q1 in Luft, we are running around about 3.8 million monthly away from the run rate that we require to hit our plan at the end of the year. Some of that is offset by income, where we're ahead of plan, and similarly in the non-pay is offset by income, but we do have a significant challenge ahead in pay. Slightly less so in Liverpool Women's. It still remains the pressure point, but I think we're more confident of eking that back during the year. So just to note, and again, I'll keep updating the committee on this to remind ourselves, we were looking to reduce our plan at Luft by just under 1,200 heads during the year. And at the moment, whilst we have seen a reduction in both budget and paid WTEs, with the biggest reduction coming in month 3 year to date, so 169 reduction in paid WTEs in month, which is pleasing. We do remain 694 WTEs short of our plan, so about 700 heads short of plan, which means that each month that we are short, the plan gets harder as well. So it's really crucial that we do hit those reductions in wards, and we look at other areas as well to, for example, medical staffing, where we've seen that we've not seen any traction yet in WT reductions. The other part to note, as I mentioned, we have seen a reduction year on year in bank and agency spend. However, in terms of the plan we set, we are still spending around about £1 million a month more than we need to. So that equates to around 2.8 million in substantive staff and 1 million additional bank and agency. So a real challenge for us, as we always anticipated it would be. If we try and consolidate, what does that risk look like for the year? There are a number of metrics we can use. If we look at the CIP and we take an assessed view using the NHSE metrics of saying, if you've transacted, it's obviously 100%. If it's deemed as a green, fully worked up, it's 75% likelihood to deliver, an amber is 50 and a red is 25. If we look at that metric across the organisations, it shows us with a risk of around about 36 million in Luft and around about 4.5 million in Liverpool Women's, based on the month 3 position. It's an improving position, but nevertheless it remains a large gap. If we take the performance, the actual performance at Q1, and just extrapolate it simply upwards, you can see the extrapolation takes us to about the same position. 34 million for Luft and 3.5 million for Liverpool Women's. We also have Simon Worthington remains contracted by NHSE and working with the patch, and I've included a slide. Simon's done a really detailed forecast now and that we have to produce monthly based on run rate and mitigating factors and non-cash factors. And Simon's analysis based at month 3, and obviously we're doing it again for month 4, is 37.5 million for Luft and 5.5 million for Liverpool Women's. When Simon's added that up across the system, he sees that replicated, and he sees a risk of anywhere between 250 million and 150 million, 130 million for the system, mid case to best case. So what does that mean for Luft? It means that as we stand at month 3, there is a risk around about triangulated risk of between 33 and 38 million pounds. Again, slightly improved from the prior month, but nevertheless significant. For Liverpool Women's, it's between around 3.5 to 5.5 million pounds. The other risk and specific risks that we called out at month 3 are twofold. Firstly, cash. The cash positions, as you can see in the financial reports, have remain low, and with it between 4 and 9 days working cash held at the end of month 3. The risk around this has been exacerbated because NHSE Northwest recommended and NHSE National accepted that in Q2 deficit support funding would be withheld from Cheshire and Merseyside. So that has an impact in cash of 11.1 million on Luft in Q2 and 3.8 million in Liverpool Women's in Q2. We hope that we can earn that at the start of Q3 if we remain on plan, but it adds significant pressure. For Liverpool Women's, that has transpired into a cash request that we've made, and thank you, Jackie, for signing at a short notice yesterday, the letter that we'd already put in, and the needed chair's signature as well. So we've asked for the 3.8 million back from Treasury, well, from NHSE for next month, and we await to hear a response. The other point that we just note there is the HMRC claim. It is in the diary for the 25th of September, and we hope that there's an upside on that, but obviously any dispute resolution, there remains a risk, so we call that out. There are 3 further risks that are not in this, are not mentioned here, but I will mention for completeness. Industrial action has been talked about, and as Jenny has mentioned, Liverpool Women is about 150,000 pounds. For Luft, we anticipated around 1.5 million. It's looking like it's going to come in around £1 million. Now we are being told to absorb that. Obviously, even if we can in month, that adds a further pressure of around about between 1.1 million currently to the forecast pressure. So that's one item. The second item is the pay award. We've now had notification of the pay award, and as we anticipated when we set the budget, the funding we've received is lower, and as the pay award has gone up, the funding received, there's an even bigger gap, and we're assessing this and await final notification of the values, but that looks to be around a further 3 million pressure for Luft and 700,000 for Liverpool Women's. We'll work through that as we go. And then the third additional risk is on income, and I was contacted by Simon yesterday. As we've called out before, overperformance can be challenged by the ICB, and the contract allows activity management schemes to be put in place. The indication is that the ICB will be wanting to do that, so we'll keep the committee informed of that risk, but that could be significant for some of our income going forward. So I'll just conclude noting that obviously the underlying deficit is there. As we know, even if we hit plan at the end of the year, there remains an underlying deficit, and we'll keep the committee abreast of that. But in conclusion, we remain with significant risk in the plan as at the end of month 3. CIP gets more difficult throughout the year, so that's going to become more acute. We have identified and closed the CIP gap, which is good. We've now got to get on with delivering it. There are some additional de-risking opportunities, not least the commercial opportunities that James is now starting to look into. With Heart and Chest coming into the group from October, that does give benefits and potential benefits that we need to start to till up. The Stay for Staffing review you've had from David, but we've got to look at fill ratios, that there might be a little bit of benefit there. And as has been mentioned previously, we do have Alan Butler working with ourselves and for Mandinagra, and Alan's looking to even further deep dive into some of our discretionary spend in particular. The third area, though, is reducing the run rate. As you've heard, it's really important. The biggest impact on that is the ward shutting and taking the WTs to TEs out associated with that. But we've also got to look at other established areas to see how we get back within our envelope. And then cash management, I've just mentioned. The final bit, just to note for committee members, and you'll see this in the papers, is just to complete the circle on the underlying deficit work and historic information. The full Simon Worthington report was included. You can see what the headlines are on all assessments. Significant progress has been made. Ourselves and NHSE have a similar profile of improvement across the years, including plan. Simon's slightly differs because in the first year it only took half of the year of the new hospital being opened, and in the current year 25-26, Simon's added a risk profile as opposed to just delivering plan. So I've detailed why that's different in the pack as well. I'll come off sharing there, Jackie, and take any questions if that's suitable.
Yes, that's fine, thank you. So yeah, difficult financially as well again, and the deficit support funding disappearing is not helpful, and the run rate we've got to hit with those other issues coming in. So is there any questions from the committee? James?
Yeah, not so much question, Jackie, just to sort of reflect on where we are. I think you look for positives amongst it. So looking at the positives, the good thing is we're at least now all really clear exactly what is factual in terms of the movement of the underlying position, which, as you know, was sort of contestable a little while ago. So that's good. We're on the same page around that between NHS England, nationally, locally, and ourselves. And I think in the context of a deteriorating underlying positions across the NHS last year, where we got to last year has been recognised in terms of improvement, which is good. In terms of this year, again, it's positive that the triangulation of the risk is consistent. So Simon's view of the risk, our view of the risk, PwC's view of the risk around the CIP programmes, all done slightly differently for various reasons, some more blunt sort of tools around proportionate relative to scheme delivery, and ours a bit more intelligent based on local knowledge. It's all coming out at a broadly similar risk. So I think there's no lack of certainty about the scale of the challenge, and the main thing is that we all understand and can take assurance in the fact that several diagnoses are giving us the same numbers. That's where the positive stuff ends. So from that perspective, we're then looking at broadly that, depending on which numbers you use, 35 to 37-ish million risk at Luft and 4 or 5 million at the Women's. Now, what Rob's described there is usually at this point of the year, this is where we sort of hold Rob upside down and shake him a bit, isn't it? And say, what have you got in the back pocket somewhere that's going to get us non-recurrently out of this? And the answer is that we haven't got anything from that perspective now in the way that maybe a few years ago we might have. There's some stuff still going on, just for total clarity and transparency, around VAT reclaim that Rob's talked to the board about before, and he's mentioned, and maybe that'll be slightly better. There's a prudent understanding of where we are, but we can't rely on it. The turnaround work with Alan Butler that Rob's mentioned, I met with Alan this morning. Very impressed actually with what he's managed to pull together in a short period of time. Rob and Alan are working through how much of that's already in positions, how much isn't, but I'm sort of cautiously optimistic that there'll be a greater improvement than perhaps the original 3 million we allocated to him, which is good. So that will take us a little bit further. Beyond that, though, we're sort of not getting to the numbers we need to, and I think the month 4, month 5 position is going to be critical here, because the reduction in the beds and the corresponding reduction in pay that we're all sort of waiting to see is going to be the key, and whether that can be then maintained into the winter. So we've got meetings with PwC the week after next, 20th of August. David Flory is coming back in for that, and we've got a session with PwC over in Warrington that is most of the day to go through the 3 trusts, including Liverpool Heart and Chest. So we'll get further guidance around what other actions they feel might need to be taken as a result. But for now, I just think it's a really challenging position. But month 4 information is going to be critical to giving us better confidence on the forecast going forward. So I'm not adding a lot there in terms of how we're going to resolve it all, but I think that month 4 numbers will give us more confidence, hopefully.
Thank you. Tom?
Thanks, Rob. It is a depressing picture. Do I understand from the Worthington report that new hospital funding is now completely off the table?
Well, if you read Simon's report, he actually accepts that a new hospital of that nature will increase the cost base. He then goes on to say, but in Leeds they weren't going to get any. There wasn't an agreed funding route, and there is no written down funding route for us. I think we remain bullish that it is a real cost, and we've seen that cost, and we can demonstrate it. And I think I suspect that will be discussed in the PwC discussions over the next months.
Okay, thank you.
Sue? Oh, sorry, David first, sorry.
Yeah, thank you. First of all, on that, when I was reading the Simon report, it did feel that the mood music on the new hospital had changed, and this would be a very political thing to do, and I'd leave it to James and David to make the judgment. But I do wonder whether the new hospital funding shouldn't appear on our risk register. And because it's we have, as I understand it, agreed numbers with the ICB and NHS England about what the costs were, so I just feel I'd be happier with that on the risk register. But as I say, the risk register is a public document. It'd be a very political thing to do. I'd bow to others' judgments on it. The other thing, it's, for me, it feels like we've made great progress. It's not where we need to be, but I can remember when NHS England rejected savings plans if you put more than 5% in because they thought they were unachievable. And that's not that many years ago. And so, great credit to everybody for the work that's going on, and well done for getting the SABA resolution. Let's hope we get the same outcome from HMRC. It feels to me, though, sort of going forward, as though we need to challenge ourselves about whether, with the income base we've got, we can afford to operate our current model of multiple sites, and whether there isn't a discussion to be had about whether, again, very difficult discussion about whether we can provide services from fewer sites and thus save some overhead costs through that approach. I put it out there, but it seems to me to be the elephant in the room, if we were in the room, about where we going forward with our plans. Thank you.
Thank you. Sue?
Thank you, Jackie. Just a couple of points, really, just on the cash position, because that's really critical, isn't it? And will be the case sort of this month, August. What do you think in terms of sort of what assurance can you give us? What feedback have you had in terms of that being accepted in terms of meeting our additional cash needs?
Well, we you have to jump through quite a few hoops these days. So we made the application, supported with a letter. Funny enough, they came back and said, well, why are you only asking for 3.8 million? So which is bizarre, seeing as he told us not to ask for anything at all. So we can't give assurance that we're going to get it, although there's a clear rationale. It was always in our plan, as is a further cash request of £15 million, but just for completeness, by the end of the year in Liverpool Women's. What we are doing and intend to take to the joint committee is we've come up with we've got set up a LASP cash group, and we are looking to enhance the recommendations from the ICB and see how we can move cash between ourselves within the 5 organisations legitimately. The easiest way being prepayments for services in year, and we're getting great support from Walton Centre, from Heart and Chest, and from Clatterbridge on that, but we're going to take that to the joint committee for a little bit of extra governance. So we're trying to mitigate, but there's no doubt about it. If we do not re-earn the deficit support funding at the end of Q2, Luft also will be requiring cash in Q3.
Okay, so we've got a plan B potentially we're looking at. Okay, thank you. I just wanted to check, you made reference to potentially increasing prices, SLAs, etc. Presumably that would impact on other trusts within the system.
Yeah, we've been working through this to try and get consistency in the first instance, and the level of overheads, and making sure we're billing for everything we do. There are some areas where we've historically not been charging, and the discussions are ongoing, not necessarily within LASP, but certainly within the NHS. And for example, there's some discussions with Mersey West Lancs. So these are difficult and political, because everyone's clearly feeling the stretch this year. But where we're providing a service, we either get paid appropriately for it, bluntly, or we can't afford to provide it. So that's our kind of stance on it. So.
Okay, that's fair. That's fair enough. So it's broader than the last trust, which is what I wanted to understand. That's fine. Just the new build insurance claim on the Royal that we had. Which impacted the last financial year, and we were sort of funded by the ICB. I just wanted to understand the risk around that in terms of 25-26 figures. Is that still a risk for us?
The legal claim monies, so that has been incorporated. So we received some funding from NHSE last year for that. And there was, which was around about half the total claim. The other half we've received via the ICB within our contractual position this year. So we are pursuing that on behalf of NHS. If we win, hopefully when we win, monies, we'll have to repay some of it. But for us, in terms of this year's numbers, that's not a variable risk for us.
Okay, so if we're not successful, it won't impact on our figures for 25-26? No, okay. Just wanted to understand that. And finally, just on the headcount.
Sorry, the timing on that is, as with all these legal cases, we've always pointed out, it might well be that it's not concluded within this year anyway. So it's probably more likely next.
Okay, I understand. And just finally, just on the headcount reduction, the 1,200 figure that we have, I just wondered in terms of visibility, particularly with the NEDs, getting assurance around that, whether we could have a bit more sort of detail about, you know, how we're, you know, dealing with that, which areas, you know, when that's likely to happen. Some of that's going to be due to sort of vacancies not being filled. Some of it's going to be due down to bank staff. Some of it's going to be, I don't think we have many redundancies, but it would be just useful to understand a bit more about how we're tackling that, just because obviously you know, you have all the detail, but for the NEDs, just to be sort of fully cited on that.
Sure. We include now in the finance report, I think it's in kind of figure 15 and 16, detailed analysis of where we've moved, both budgeted and paid WTEs. I think there's some at our senior management board, there's some further plans coming back this time from the sites as to the headcount initiatives that are coming forward, so we can certainly update on that as well.
Great, thank you.
Okay, James and Jeffrey, just before you start, James, I'm just recognising I've gone over the end of the meeting, so hoping people are able to stay that little bit longer. So over to you, James.
It was just a brief one to say, in response to the new hospital stuff, we are going to be discussing that on the 20th with PwC. Whilst Simon Worthington report intimates one view, Stephen Hay from PwC gave us a different view when we met with them last, whereas he didn't say that was a definitive and the numbers that were correct, that needed to be looked at, but he felt he could see that there was a structural problem there that needed to be addressed one way or another. So I think that's an important thing to discuss on the 20th. If there is a recognition of that on the 20th, which I would think there will be, then I agree with David Gilbert that we should then put that in our risk register so that it sits more clearly as an organisational risk contributing to the financial problem. Thanks.
Thank you. Jeffrey?
Just quickly on Sue's point, I think I raised this at the board in terms of having more visibility in terms of the headcount reductions on a kind of linear graph process month by month. If we could start to incorporate that, but I think Sue's point I agree entirely with. And the point about the MWL and the being paid for, what MWL is really hot on is coding. So when I was at the CCG, they made sure they got paid for every single thing, and you couldn't get behind them. So they're very hot on that, and it is a route to making sure you're being paid for everything. Is that your coding is really red hot?
Well, absolutely, and the point that James alluded to, or mentioned before, about the risk within the finance team functions. One of the things we're seeing is that we've got vacancies in some of our coding areas, in some of our senior posts, and as we get into this world of more granularity around finance and finance asks and going almost back to PBR, I think that's somewhere we need to focus, which is part of that risk why we put it on the register.
Coders are not a group of staff you can afford to reduce the headcount on.
No, albeit that there are digital ways that, and again, EPR should help with that, but absolutely agree.
Thanks, Jackie.
Thank you. Okay, no more questions. Your next paper, Rob?
Yes, so this is the PwC report. At the start of the financial year, PwC were asked to come and do a rapid diagnostic, or another rapid diagnostic on the system. They did that. I think the reports were circulated to board members on the 23rd of July, as soon as we received them for Liverpool Women's and for Luft. What we've taken here for completeness is the summary finding, the summary findings and recommendations. So each organisation within Cheshire and Merseyside, everyone got an overall position from PwC and then got a sub-report that was private and confidential. So the two reports here are for Luft and for Liverpool Women's. You can see our response to the recommendations, and they're largely positive. Just a couple of points to note. Consistent on the red is obviously the case for change, where the recommendation, so it's recommendation 6 for Luft and well, for both organisations. We've marked that as work ongoing, but as we know, there's continuing discussions around that. The recommendation was that we get clarity on that as quick as possible, which I think we would all welcome. The other recommendation for both organisations is identify your CIP, which we both have, and to have that 75% as blue or green, transacted or basically nearing completion by the end of July. It looks like we're going to be short a little bit. I think Liverpool Women's will be about 70%. We're still consolidating on Luft, but I think we're going to be slightly under that 75% target. Having said that, what they also ask us to do is to make sure that we don't just make the numbers fit, that we have a robust process, and that involves QIA, EIA, which David kindly chairs for us as often as we require, and we do a really thorough process. So I think we will be short of that target in both organisations, albeit we are seeing continued progress each month, and we will be 5 to 10% short, but we'll continue to work on it. Happy to take any questions that we've noted. Our response and our residual risk remaining in all of the areas, including some of those human resource risks around staff fatigue on CIPs and morale and etc., which I think are important to call out as we go through these difficult programmes.
Thanks, Rob. Any questions for Rob on that paper? James?
Not a question on the paper as such, as just more of a, I think as a board, the work with PwC on a regular basis now will particularly focus on board oversight of these issues. There's clearly a set of recommendations and a plan there. We'll bring that back through this committee on a monthly basis. But again, where there's reference to things that might have overlap with the audit committee, I think it would be good for Rob and David just to perhaps have an offline conversation about are there any things here that will be stronger taken through that route, and likewise Sue for the women's. So not to take time on it now, but perhaps outside of the meeting we could just take another look at the plan and say where we want greater assurance of the things the audit committee might want to have some oversight of in regards to that report for the two organisations and the action planning around it. So if we could maybe action that, Jackie.
Yes, thank you. We'll capture that for the action log. Thank you. Okay, if there's no other issues, is there any other business? David?
Yes, thanks, Jackie. I realise we're running over, but just quickly, we've been battered by Storm Florrie this week. I just wondered if that was anything to do with your meeting with NHSE, James. Or how will we get the briefing from that?
Which one?
Oh, I understand the storm. It's the meeting with NHSE.
No, that's what I meant. Which meeting with NHSE? Sorry, you're referring to?
I understood there was one with the chief executive of NHSE last week.
My apologies. Cancelled.
So that explains Storm Florrie.
Yeah, well, it was actually cancelled by the NHS CEO the day before due to the strike issues, and he was being constantly called away, and he didn't want us to go and then not be present. So it is being rearranged. Thanks, David. I should have mentioned that. So that's being rearranged for a few weeks' time. we have got now some really clear information from Jim and Louise at Northwest on the way forward, and that's all been detailed in an email. So what we'll do is I'll get Daniel to get that round to board members so everyone can see the latest position on what's going to happen. And this morning I've been contacted to set the first of those meetings up locally. So the email will explain it better, David, than I can on the meeting, but that was cancelled and there'll be a future one in a few weeks.
Right, thank you. Thanks, Jackie.
Thank you. So if there's no any other business, I thank you all for your contributions. I think it's been a good meeting. I think we've had some good discussions and we've got the assurance that we're looking for, but recognising the work we've got to do, especially around the finances. So thank you for your contributions, and I'll call the meeting to a close. Thank you.
Thank you.
Okay, bye.
Thank you.